Okay, so now the next major topic we're going to go to is the topic of lymphomas. And we're going to talk in detail about this, about Hodgkin's lymphoma and a non-Hodgkin's lymphoma. But before we go on, firstly let's define what is a lymphoma. We can say a lymphoma is a collection of lymphoid malignancies where malignant lymphocytes accumulate at the lymph nodes and at lymph tissue. It's a group of malignancies where the lymphocytes accumulate at the lymph nodes and lymphoid tissue, therefore causing a lymphadenopathy. Okay, so malignant lymphocytes accumulate at lymph nodes and lymph tissue, therefore causing a lymphadenopathy. Okay, so this is typically what we can say. Now to diagnose this, the typical way is to do a biopsy. You biopsy the lymph node and you'll see whether the lymphoma is present. And you'll see that a lot of them are from B-cell origin. So a lot of the lymphomas are of B-cell origin. Okay, so let's just make a note of that. Biopsy, important. And B-cell origin, usually. So most of them are of B-cell origin. Now, when we classify the lymphoma, especially the non-Hodgkin's lymphoma, there's a specific way we can do this. We can say something is a low-grade tumor or a high-grade tumor. Okay, and this depends on the proliferation rate. So we look at the proliferation rate and we see if it's high, it's going to be a high-grade tumor. If it's low, it's going to be a low-grade tumor. So classification. We can have a high-grade, or we can have a low grade. Okay, and this is all going to depend on our proliferation rate. Proliferate. Okay, and depending on this, especially on this, it's going to tell us whether we have a high grade lymphoma or a low grade lymphoma. Now, if we start by talking about the high grade lymphoma, we can say in this kind, the cells are going to divide very rapidly. Firstly, high cell division. So division is rapid. Rapidly. In this situation, we can say that it can present weeks before the diagnosis. So it can be there weeks before the diagnosis, not months, not years, because the proliferation rate is so high. So weeks before diagnosis. And in a high grade, most importantly, we can say it's life-threatening. In a lot of the situations, it's going to be a life-threatening situation in a high-grade lymphoma. So life-threatening. If we talk, however, about a low-grade lymphoma, we can say it divides very slowly. It's not a rapid growth. It can be present for months or even years before the diagnosis. And usually, it's not life-threatening. It's a complete opposite. Divides slowly. Months, let's say months before diagnosis. And we can say it's not life-threatening. So it's much slower and it's much less serious than a high-grade lymphoma. High-grade lymphoma is very bad. All of these can be staged using something called the Ann Arbor classification. Okay, so now we have a brief idea about lymphomas. We know what a lymphoma is, we know how it's diagnosed, we know that a lot of them are of B-cell origin, and we also talked a bit about the classification of a high-grade lymphoma to a low-grade lymphoma. Now just to go into a specific kind, which is a Hodgkin lymphoma, and then later on we'll come into a non-Hodgkin's lymphoma and talk about the differences. In this case we can say it's a malignant proliferation of lymphoid cells, just like we said for a normal lymphoma. And the most important thing is to know the histological hallmark of Hodgkin's lymphoma, which is the presence of Reed-Sternberg cells, specific cells called Reed-Sternberg cells. The histological hallmark is Reed-Sternberg, specific to Hodgkin's lymphoma cells. Okay, so specifically what we can say a Reed-Sternberg cell is it's malignant, it's very large, and it's a lymphoid cell of B cell origin. Malignant, large lymphoid cell of B cell origin. So, malignant, large, and it's of B cell origin, just like we said most lymphomas were. So it comes from B cells. Most lymphomas come from B cells, B cell origin. The Reed-Sternberg cell itself usually isn't present in high numbers. So it's a very small number of Reed-Sternberg cells, but they're surrounded by certain other cells. And these cells can be T lymphocytes, they can be non-malignant, so completely healthy T cells. We can have eosinophils, and we can have plasma cells. Okay, so all of these can surround the Reed-Sternberg cell. Now, just to talk about the types of Hodgkin's lymphoma, we can split into two main categories. We can say we have the classical Hodgkin's lymphoma, which we can split into four different types, four different histological types, depending on the appearance of the Reed-Sternberg cell and the appearance of the surrounding cells. So that's number one, a classical Hodgkin's lymphoma. Okay, and we say in this situation we have four subtypes depending on the morphology of the Reed-Sternberg cell. The second type we can have is a nodular lymphocyte predominant Hodgkin's lymphoma, a nodular lymphocyte predominant. Nodular lymphocyte predominant. Okay, so this is not a very common kind. It makes up only 5% of the Hodgkin's lymphoma. It's very slow growing, it's very localized, and it's very rarely fatal. So slow growing, rarely fatal. Okay, but like I said, it's only one that makes up 5% of the Hodgkin's lymphoma. So we can have classical or nodular lymphocyte predominant Hodgkin's lymphoma. Hodgkin's lymphoma, the histological hallmark is a Reed-Sternberg cell. Reed-Sternberg cells are going to be surrounded by other cells, T cells, plasma cells, eosinophils. These Reed-Sternberg cells are malignant, large, and of B cell origin. To classify this, we have the classical type, which we have four subtypes depending on the appearance of the Reed-Sternberg cell and the surrounding cells, or the nodular lymphocyte predominant type, which only makes up 5%, and is slow growing, is localized, and is rarely fatal. So clinically, what are we going to see in a Hodgkin's lymphoma? What are the main things we should look out for? We know, of course, in a lymphoma, lymphadenopathy is very important. So in a lot of situations, we could have a lymphadenopathy, and this is going to be a painless, rubbery lymphadenopathy, mostly in the neck, maybe in the supraclavicular fossa also. So painless, rubbery lymphadenopathy. Typical sign. Also, patients may present with splenomegaly, a severely increased size of the spleen. Splenomegaly. Also, in certain types of Hodgkin's lymphoma, in the nodular sclerosing type, which is what we talked about, the nodular type before, we can have a mediastinal mass. A mediastinal mass can develop, and this can cause the patient to cough and cause breathlessness because of the compression of the lungs. So coughing and breathlessness is also a possibility, and detecting the large mediastinal mass on imaging, weightless. Okay, but only in certain kinds of Hodgkin's lymphoma this is going to be present. In a lot of the other kinds there'll be no mediastinal mass. Also importantly, non-specific symptoms, things like weight loss, night sweats, fever, very non-specific symptoms might be important to look out for. So non-specific. Okay, so mainly lymphadenopathy, splenomegaly, cough and breathlessness if there's a large mediastinal mass in certain kinds, and non-specific symptoms, weight loss, night sweats, fever. They say that the spread of this malignity from lymph node to lymph node is contiguous, and it goes from lymph node to lymph node which are adjacent or which are close by. So it goes to the close lymph node first, then slowly spreads around the body. Okay, so in this we can say contiguous spread. Contiguous spread. Okay, so to the adjacent lymph nodes, spreading within that region first before going to any other areas. And of course we have to stage this via the Ann Arbor classification. Now to investigate this disease we're going to have to do a large number of tests because the disease can spread. It can go from lymph nodes to lymph nodes around the body and can affect a lot of the different organs. So investigations, of course, first is first, full blood count. Okay, and it's possible on a full blood count that we see a lymphopenia, a decrease in the number of lymphocytes, which is actually a poor prognostic factor. Okay, so lymphopenia is something that's not going to be good in this situation, so we don't want lymphopenia. It's possible that the ESR, the erythrocyte sedimentation rate, may be increased because of the inflammation. If the disease is spread to the liver, then possibly liver function tests might be important. So LFTs, if it's spread. Other tests, of course, we talked about the large mediastinal mass causing cough and breathlessness, so it's important to have a chest x-ray to see if there's any mediastinal mass. Possible CT scan to stage the disease to see how far it's spread. So x-ray for the mediastinal mass and CT scan to stage. Okay, so these are typical tests. We might have to do also other tests to ensure that other organs aren't affected. But obviously, most importantly, to diagnose this, we have to do the lymph node biopsy. Okay, and this is going to be done with radiological guidance, but it has to be done. So a lymph node biopsy. So clinically, we said painless lymphadenopathy is very important. Painless rubbery lymphadenopathy in the neck or supraclavicular. We can have a mediastinal mass in certain kinds. We can have splenomegaly. We can have non-specific symptoms like night sweats, like weight loss. Very important to check for. It's a contiguous spread from adjacent lymph nodes, from lymph nodes that are connected. And you have to look at an Ann Arbor classification to classify this properly. Investigations. We have to do widespread investigations, full blood count to see if there's a lymphopenia, liver function test to see if it's spread to the liver. We can do a CT scan to see if there's any, to see the staging of the disease, how far advanced is it, an X-ray to see if there's a mediastinal mass, to possibly to say it's a certain kind of Hodgkin's lymphoma. And of course, a lymph node biopsy is very important to diagnose the disease and to confirm suspicions. We can say that it very much depends on the staging of the disease, whether it's very early or it's late. In an early stage, for example, stage 1A or stage 2A, then radiotherapy and chemotherapy can be given. Early on, before they used to give only radiotherapy, but apparently after tests they found that it was more successful with radiotherapy as well as chemotherapy. So what we're going to do is discuss radiotherapy briefly, and then just go on to the chemotherapy and talk about the specific regimen which is used there and used in Hodgkin's lymphoma. So let's start with radiotherapy on this side, and we'll have chemotherapy on this side. Okay, the radiotherapy is reasonably brief. Okay, now we can say any woman who's being exposed to radiation at the chest is of course going to increase the risk of breast cancer, of that person developing breast cancer. So it's very important to have a strong breast cancer screening program. Okay, an effective breast cancer screening program. Okay, so that has to be in place. Secondly, anyone with lung irradiation, especially smokers, are going to increase the chances of lung cancer, especially smokers. So increase in lung cancer in smokers when we have lung irradiation. Okay, so two things to keep in mind: breast cancer screening program and lung cancer in smokers increase chance from lung irradiation. So now chemotherapy. Like we said, in an early stage they used to only use radiotherapy, apparently no confirmation, but now with chemotherapy they find it's more effective. With chemotherapy we have to talk about a specific regimen, the ABVD regimen. Okay, now this consists of 4 drugs which are supposed to be very effective and very widely used in the UK. I'm not sure about the States, but it's very widely used in the UK. And the drugs are, alright, bear with me here, doxorubicin, bleomycin, vinblastine, and dicarbazine. Alright, so it's a successful treatment. It's supposed to be very effective in Hodgkin's lymphoma, and it gets a lot of patients into remission. Like I said, it's very much used in the UK, and I think also in the States. However, the downside is that with this regimen, it can cause cardiac problems and it can cause pulmonary problems. So it's not uncommon to have cardiac problems and pulmonary problems because of this. And once the treatment is given, of course you have to monitor the patient, see what the situation is. You have to possibly give regular CT scans, possibly a PET scan is an option, to monitor how the person is reacting to this ABVD regimen. Okay, so let's say it's in the UK, it's used CT scan / PET scan is possible, and it's very effective, but can cause cardiac or pulmonary problems. Okay, so if it's been used for a long time, possible cardiac and pulmonary problems. Okay, so this is in a early stage disease, in a not very advanced disease, radiotherapy and chemotherapy. Now they say that if it's a very advanced disease, if it's very late, an advanced stage disease, we give chemotherapy alone with a possibility of introducing radiotherapy if it doesn't work. So they say 6 to 8 cycles of this ABVD regimen have to be given if it's an advanced stage disease. And if there's no reaction after all of this, if it's an advanced stage and still there's no reaction, of course you have to consider a bone marrow transplant in certain individuals that qualify for this. Okay, so let's say this is an early stage. Early, we're going to give chemotherapy and we're going to give radiotherapy. In a late stage, we'll just give the chemotherapy with a possibility of radiotherapy, but they say it's just with the chemotherapy, and that's 6 to 8 cycles of this ABVD regimen. 6 to 8 cycles of the ABVD regimen. Okay, now the prognosis. So we talked about the early stage, we talked about the late stage. The prognosis, we can say it's a very, very good prognosis usually. 90% of patients go into remission, and something like half of those patients are cured. So they're completely cured of everything to do with the the disorder. Even, so this is an early stage. If it's an advanced stage, again, the prognosis is quite good. Something like 60 to 70% can go into remission, and just under that can be cured. So the prognosis of this disorder, a Hodgkin's lymphoma, is actually very good. Okay? So prognosis. In an early stage and a late stage, the prognosis is actually quite good. So Hodgkin's lymphoma management, radiotherapy and chemotherapy in an early stage disease. We give both. Radiotherapy, make sure we have a good breast cancer screening program. Make sure we know that lung cancer has an increased chance if there's lung radiation, especially in smokers. Chemotherapy, ABVD regime, doxorubicin, vinblastine, bleomycin and dacarbazine. Very important, you monitor this patient once this is enforced with a CT scan or a PET scan. Can possibly cause cardiac problems and pulmonary problems, so be on the awareness, be on the lookout for this. In an early disease, we treat with chemo and radiotherapy. Apparently now it's more effective. Late, just chemotherapy, 6 to 8 cycles, with the possibility of radiotherapy being introduced. The prognosis of Hodgkin's lymphoma is very good, even in a late stage disease. So I think that's enough for Hodgkin's lymphoma, and I think we can now go on to discuss the non-Hodgkin lymphoma. In a non-Hodgkin lymphoma, we can say it's a proliferation of either B cells or T cells. So in 70% of the cases, we have a B cell proliferation, and in 30% of the cases, we have T cell proliferation. So proliferation of either B cells or T cells. The B cells, we can say, are 70% of the time it's B cells, and then 30% of the time we have T cells. So proliferation in Hodgkin's, we said it was B cells. In non-Hodgkin's, it can be a B cell or a T cell. Again, just like the others, it can appear in the elderly more commonly, and we specifically spoke at the beginning about a classification. We said high-grade lymphoma and low-grade lymphoma. This is especially important in the non-Hodgkin's lymphoma. We said we have high-grade and we have the low-grade. Okay, and we specifically mentioned some features. I won't write everything again, but we said for the high-grade, high proliferation rate, we're going to have symptoms occurring very early on before the actual diagnosis, and it's going to be potentially life-threatening. For the low-grade kind, it's going to have a low proliferation rate. Usually it can be asymptomatic for many months, and usually it's not life-threatening, so it's not as serious as the high-grade lymphoma. So it's important we know this grading system. We have this in mind, especially for the non-Hodgkin lymphoma. Okay, now for the etiology. So why does a non-Hodgkin lymphoma develop? We can mention two main things. Firstly, we can mention chromosomal translocations. So for the etiology, one, chromosomal. Okay, so certain kinds of lymphoma, for example, a follicular kind of lymphoma, can be linked with a certain translocation. In a follicular type, we have a translocation with chromosome 14 and chromosome 18. So because of this translocation, it's going to inhibit cell death, and it's going to cause the development of a non-Hodgkin lymphoma. So, for example, follicular lymphoma, is a translocation with chromosome 14 and chromosome 18. Okay, so that's the first thing. We can talk about chromosomal translocations messing up the cell death process. Secondly, we can talk about viral infections. So certain viral infections can be associated with a non-Hodgkin's lymphoma. Infections like HIV, very importantly, like Epstein-Barr. I think also HCV could be one. So HIV and Epstein-Barr we'll keep in mind. So viral infections another possible thing to keep in mind, especially HIV, and that will come onto that in the testing, and possibly Epstein-Barr. Okay, so EBV infection. Okay, so these are the typical things we need to look for on the etiology. So clinically, what are we going to see in a non-Hodgkin's lymphoma? Clinically, typical things. Again, it's a lymphoma, so number 1, lymphadenopathy. Number 2, just like in a Hodgkin's lymphoma, we should look out for a splenomegaly or possibly an hepatosplenomegaly, depending on how spread the disease is. So spleno/hepato splenomegaly. Okay, possibly also we can have bone marrow involvement. In some situations the bone marrow is affected, anemia, bleeding, infection rates are increased, and this is especially in the low grade diseases. So bone marrow involvement. Okay, and especially in the low grade. In about half of the cases of low grade non-Hodgkin's lymphoma, we can have bone marrow involvement. Also possible is compression syndromes in very severe cases, and very rarely we have compression syndromes that can cause ascites, that can cause gut obstruction, that can cause spinal cord compression. So only in rare cases. In rare cases, compression syndrome, spinal cord, gut obstruction, ascites. Okay, so these are typical things that we should look out for clinically when assessing someone with a non-Hodgkin's lymphoma. Investigations. Okay, so for investigations it's going to be very similar to a Hodgkin's lymphoma. So look back at the Hodgkin's lymphoma tape and just add on a few other investigations. Okay, so let's say investigations, Hodgkin lymphoma plus more. Okay. Now we said in this situation we can have B cells or T cells. So it's important to do an immunophenotyping to know whether we're dealing with B cells or T cells. So number 1, immunophenotyping. Okay, we'll determine whether it's a B cell from a proliferation or a T cell proliferation from this immunophenotyping. We can also look at uric acid levels, possibly because it's an increased cell turnover. And importantly, we possibly have to do HIV testing, because we said with this condition, it's possible viral infections can be the reason why this is developed. So if the risk factors are there, then possible HIV testing. HIV test, if possible, risk factors. If. Okay, so not in every situation we're going to do HIV testing. Okay, so just a quick word about the management now, a management of a non-Hodgkin's lymphoma. We said that it's very important to know the grade of the lymphoma, whether it's a low-grade lymphoma or a high-grade lymphoma. In a low-grade lymphoma, we have a low proliferation rate, high-grade, high proliferation rate. It's important, I don't think we mentioned it before, in a low-grade lymphoma, you have the potential to, no, you do not have the potential to cure. But in a high-grade lymphoma, you have the potential to cure. I'm not sure why that is, but in a high grade, you do have the potential to cure. Okay, so if a patient has no symptoms and has a low-grade lymphoma, possibly you can watch and wait and give no therapy. No symptoms, no therapy. Watch and wait. But if the person does develop symptoms, then of course we have chemotherapy, we have radiotherapy as options. So option number 1, option number 2. Chemotherapy can be with a drug we mentioned before, which is chlorambucil. I'm not sure how successful that is, chlorambucil. And radiotherapy can be given in certain situations, especially I think in a stage 1 disease, a very early on localized disease. Radiotherapy can be given. A third kind of treatment, an interesting one, is called monoclonal antibody therapy. And basically what we do is we give antibodies that target surface antigens of the tumour cells. So the tumour cells have surface antigens, and the antibodies are going to target these antigens, and they're going to induce apoptosis of the cell. Okay, so this is monoclonal antibody therapy. And specifically we can talk about a drug called rituximab, which is an anti-CD20 antibody, and it's supposed to have a very successful effect. So monoclonal antibody therapy. Okay, and we can specifically, so let's say there's antibodies against that target surface antigens on tumor cells. Okay, when this happens, what we want to do is induce apoptosis. Okay, so this is going to be the effect of this monoclonal antibody therapy, and we said we have this drug rituximab with an X, and this is an anti-CD20 antibody. Of course chemotherapy, of course radiotherapy, but monoclonal antibody therapy with rituximab is a big option, and it has a high success rate. It has a good response in over 60% of cases, so a good chunk of the population with non-Hodgkin's lymphoma have a good response with rituximab, greater than 60%. Okay, now in some situations rituximab is not going to be given alone. It's usually given with other drugs, a cocktail with rituximab, with cyclophosphamide, which we mentioned before, vincristine, and also corticosteroids in the form of prednisolone. Okay, and this is going to make up something called, let's do it in a better colour, RCVP regimen. Okay, the RCVP regimen. It's going to be made up of rituximab, it's going to be made up of cyclophosphamide, it's going to be made up of vincristine and prednisolone. These 4 drugs together are going to make this RCVP therapy for non-Hodgkin's lymphoma. Rituximab, cyclophosphamide, vincristine, and prednisolone. Okay, so all these in combination, they say has a high success rate in treating a non-Hodgkin's lymphoma. All of these together. Now, of course, the 4th option, which we talked about before also, is of course a bone marrow transplant. So if the person qualifies, you can give a bone marrow transplant. So it's another possibility. 4th possibility, bone marrow transplant. Okay, so these are the main options in the management of a low grade. This is for low grade non-Hodgkin's lymphoma. Chemotherapy, radiotherapy, monoclonal antibody therapy with specific antibodies targeting antigens, and an anti-CD20 is rituximab, 60% success rate, very, very successful, and can be used in combination with other drugs in RCVP regimen with rituximab, cyclophosphamide, vincristine, prednisolone, and a 4th option is with a bone marrow transplant, and this is for a low-grade treatment of non-Hodgkin's lymphoma. Okay, so now the management of a high-grade non-Hodgkin's lymphoma. Again, the first things we can talk about are, so we said high-grade, high proliferation rate, but with a potential chance to cure. Now we can talk about radiotherapy again, and we can talk about chemotherapy again. Okay, just like in the low grade. With the radiotherapy, there's certain indications of when you can use a radiotherapy in a high grade situation. First is in certain kinds of stage 1 disease, so very early disease without a bulky disease, possibly localized. So stage 1 localized disease. So let's say stage 1, let's say localized. That's the first indication. The second indication of radiotherapy in a high-grade lymphoma would be if there's a residual site of the disease after using chemo. So if you used chemotherapy, but still there is a part where you still have the disease, you still have the effect of the non-Hodgkin's lymphoma, and you can radiate this one area and then get rid of the residual disease. So residual after chemo. That's the second indication. Okay, so we said there's 3 indications. The third final indication is in some kind of compression syndrome. So we said you can have an ascites, you can have spinal cord compression, and possibly in a compression syndrome, radiotherapy might be the best way to go. Okay, just to get that site, that localized area that's causing the compression to be relieved. Okay, so that's radiotherapy. Okay, now with the chemotherapy, again, similarly to the low-grade treatment, we're going to have a cocktail of 4 drugs. We're going to have 5 drugs in this case. We're going to have 5 drugs, but the chemotherapy is going to be 4. Chemo, cyclophosphamide again. We're going to have doxorubicin. We're going to have vincristine, and we're going to have prednisolone. Cyclophosphamide, doxorubicin, vincristine, and prednisolone. Okay, in this combination, along with rituximab. Okay, so in this combination, if it's just the chemotherapy, if it's only the chemotherapy, we have doxorubicin, we have prednisolone. Okay, so I just want to get this clear. We have 4 drugs in the chemotherapy, but then we can combine it with the monoclonal, which we're going to talk about next, to have 5 altogether. Doxorubicin, prednisolone, cyclophosphamide, and vincristine. Cyclo and vincristine. Okay, so in this situation we have these 4 drugs, and then we can add this to the monoclonal antibody therapy with rituximab, and when we have all of this, we have something called R-CHOP therapy. R is for rituximab, and the rest is for this. Okay, so R-CHOP therapy. This is the first line treatment in a high-grade non-Hodgkin's lymphoma. R-CHOP therapy with monoclonal antibodies. So let's just say radiotherapy was number 1, chemotherapy was number 2, number 3 we can have as monoclonal antibody therapy, and when we combine the chemo with these 4 drugs and the monoclonal antibody therapy with the rituximab, we're going to have eventually R-CHOP. Okay, and this is the first line therapy in a high-grade non-Hodgkin's lymphoma. And of course, again, just like before, in the low grade, we can talk about a bone marrow transplant in certain situations. Okay, so these are the treatment options. Okay, so just a quick word about the prognosis of non-Hodgkin's lymphoma, the final point. We can say that if it's a low-grade disease, then it's going to be a remitting, relapsing course throughout the progression of the disease, with a median survival of about 10 years, 10 to 12 years. In a high-grade disease, a lot of the people react very well to the therapy, but the prognosis is still very poor. So again, I expected a remitting, relapsing course, and with the prognosis eventually not being very good. They have something called the International Prognostic Index, which gives a more accurate prognosis because it takes into account the age of the person, the LDH levels, the Ann Arbor classification, and using all of this in a complicated way, they come to a final prognostic diagnosis. So what they think the prognosis will be, whether it's a poor prognosis or a good prognosis. So I think that rounds off non-Hodgkin's lymphoma. Okay, so the next topic to discuss is going to be paraproteinemias. Now, before discussing what exactly paraproteinemia is, I think it's important to define a term which is gammopathy. A gammopathy is basically the overproduction of one or more of the classes of the immunoglobulins, one or more. Depending on how many, we can define whether it's a monoclonal gammopathy or a polyclonal gammopathy. So we can say overproduction of 1 plus 1 or more of the immunoglobulins. Okay, and depending on how many of them are increased, we can say if it's a polyclonal gammopathy or a monoclonal gammopathy. Of course, a polyclonal gammopathy is going to be an increase in more than one of the immunoglobulin classes, and mono is going to be 1. So one single increase is a monoclonal gammopathy, more than one is a polyclonal gammopathy. In a polyclonal gammopathy, we can see this in infection. Certain infections can cause polyclonal gammopathies, and certain chronic inflammation can cause polyclonal gammopathy. So infection and inflammation are the typical situations where we can see a polyclonal gammopathy. For the monoclonal kind, we can see in things like myeloma, lymphoma, HIV infection, rheumatoid arthritis. They all typically have monoclonal gammopathies. So rheumatoid arthritis, lymphoma, myeloma, HIV. Okay, all typically have these overproduction of one of the classes of immunoglobulins, a monoclonal gammopathy. A monoclonal gammopathy, we can say, is a paraproteinemia. Okay, so these can be interchanged, paraproteinemia and a monoclonal gammopathy. So an increase in one of the lines of immunoglobulins. Now, to detect a gammopathy, we have to do a plasma electrophoresis. And this is where the blood is going to be exposed, the plasma is going to be exposed to an electric current, and then it's going to separate the proteins by size and by charge. Okay, so a plasma electrophoresis is how we're going to diagnose this. This is diagnosed with a plasma electrophoresis. And of course it's going to separate by size and by charge. Okay, so I think now we kind of know what a paraproteinemia is, or a monoclonal gammopathy, and we can go into a few of the diseases that demonstrate this kind of thing. Okay, so the first paraproteinemia that we want to discuss is going to be Waldenstrom's macroglobulinemia. In this condition, there's two important characteristics that we have to talk about. Firstly, we're going to have a proliferation of lymphoplasmacytoid cells. Lymphoplasmacytoid cells. Okay, so that's number one. Proliferation of lymphoplasmacytoid cells. Number two, the second characteristic is we're going to have the presence of a monoclonal IgM paraprotein. Presence of monoclonal IgM paraprotein. And we're going to talk about what this means in a moment. Clonal IgM, important to know, IgM paraprotein. Okay, so let's take the first point. We said we have a proliferation of lymphoplasmacytoid cells. A lymphoplasmacytoid cell is basically a hybrid between a B cell and a plasma cell. It's in the process of maturing from a B cell to a plasma cell. Because initially, we're going to start with our B cell, and then eventually, after maturation, it's going to become a plasma cell. Okay, and at this point, it can start secreting the immunoglobulins, the antibodies that it usually does. Okay, so once this maturation is done, if it's caught in the middle, a hybrid between a B cell and a plasma cell, then you have a lymphoplasmacytoid cell. So in this condition, Waldenstrom's macroglobulinemia, we're going to have a proliferation of this cell, the hybrid of these two cells. Now, the second one, we said IgM paraprotein. We said it's a monoclonal gammopathy, and we have an increase in one of the immunoglobulins. And in this case, we're going to talk about IgM. So there's going to be a severe, significant increase in IgM. And because of this significant increase, it's going to lead to a certain syndrome. This is going to be packed in the blood. So it's going to cause something called a hyperviscosity syndrome. Hyperviscosity syndrome, and this is going to give us a lot of the symptoms that we see, a lot of the signs that we see in this pathology. So this is going to cause hyperviscosity syndrome. Okay, so this means that because the blood is so congested, because the blood cannot function like it should do, it's going to cause certain features. Now, if it's viscous, then we know that the platelets won't be able to function properly. So you're going to have impaired platelet function. This is going to cause things like nosebleeds. It's going to cause things like bruising because of the platelet dysfunction. So we're going to have nosebleeds. We're going to have bleeding or bruising. These are just hematomas developing. Secondly, so these are the problems because of platelet dysfunction. We can also have features like confusion because there's decreased blood flow to the brain because it's not flowing like it should do. There's less cerebral blood flow, which means possibly headaches, confusion, and possibly more severe things. So let's just say for now, confusion. Confusion. Also, possibly we might have problems with the vision because there is retinal venous engorgement and the blood flow to the eyes again is not properly. The vessels of the eyes, it's not working properly. So, vision problems. Vision problems also. Nosebleeds, bruising, confusion, vision problems, typical things that we should see in a hyperviscosity syndrome due to the elevation in the IgM. Okay, other features we might see. So now we're talking clinically. Other features we might see are things like splenomegaly, of course. Also more typical things like lymphadenopathy, like anemia because the red blood cells aren't functioning properly. So lymphadenopathy, anemia. Okay, so typical things to expect clinically when speaking about Waldenstrom's macroglobulinemia. So if we investigate a Waldenstrom's macroglobulinemia, let's go straight into a blood film. What are we going to see? Investigations, blood film. What are we going to see? Possibly, of course, we can see these lymphoplasmacytoid cells. So if they are in the blood, the lymphoplasmacytoid cells is possible. If they're in enough numbers, that we can see them on a blood film. Second interesting thing we might see is something called a rouleau formation. Okay, and this is basically when the red blood cells start to stack on each other. They make a stack of red blood cells. And this is because usually the red blood cells are negatively charged. Okay, so they repel each other. They make sure that they don't come together. But because of these high levels of IgM, which is a protein, it's going to balance out the charge. It's not going to be as negative anymore, which means they're going to come together. Okay, so the charge isn't going to be negative to repel each other. It's going to be so they can come together and they can form these stacks of red blood cells. Okay, so a possible rouleau formation. Okay, and this is possible in situations where the erythrocyte sedimentation rate is high, so in inflammatory disorders you can have a rouleau formation. So now the management and treatment. If it's a very severe Waldenstrom's macroglobulinemia with very severe symptoms and the hyperviscosity syndrome is causing a lot of problems, then it's possible that we can do something called a plasmapheresis to remove the IgM. So we can get rid of the IgM via something called a plasmapheresis. Okay, so that's the first option, plasmapheresis. Option number one. Secondly, of course, there's drug therapies out there. Sometimes they say they use alkylating agents like chlorambucil, which we talked about before, chlorambucil. Also the monoclonal antibody therapy with rituximab is also common. So let's say chlorambucil. Rituximab. So it has more than one indication in hematology. Okay, and the third possible treatment will be corticosteroid treatment, because there could be severe inflammation in this kind of disease. The corticosteroids can be given to decrease the inflammation. So corticosteroids may also be an option. Okay, so Waldenstrom's macroglobulinemia was the first paraproteinemia that we discussed. We said two features that we need to know. There's going to be proliferation of lymphoplasmacytoid cells, and there's going to be the presence of the monoclonal IgM paraprotein. We said a B cell has to mature to a plasma cell, and if we catch a hybrid of this, we have a lymphoplasmacytoid cell. The IgM levels are going to be very high in the blood, causing a hyperviscosity syndrome. The hyperviscosity syndrome is going to cause a lot of problems in the body. It's going to cause nosebleeds, it's going to cause bleeding, confusion, vision problems. Other features may be splenomegaly, lymphadenopathy, severe anemia could develop also. The investigations, especially on a blood film, we can see these lymphoplasmacytoid cells possibly, and also the rouleau formation because of the change in the charges of the red blood cells, meaning that these can form. In the treatment for this, we can do a plasmapheresis, and we can do a chlorambucil therapy or rituximab as an alkylating agent or an anti-CD20 therapy, and also corticosteroids possible to reduce the inflammation of the disorder. Just one quick thing that I didn't mention in the investigations, we talked about a blood film. Also a bone marrow examination might reveal some interesting stuff. Of course, we can possibly see these lymphoplasmacytoid cells again in the bone marrow. If they're not going to be in the blood film, of course they're going to be in the bone marrow. But we have two other things that we might see. So lymphoplasmacytoid cells, but two other things. Something called a Ducho body and something called a Russell body. They're very similar things. They're described as eosinophilic inclusions in the nucleus and in the cytoplasm respectively. So if it's in the nucleus, it's a Ducho body. If it's in the cytoplasm, then it's a Russell body. Okay, so we're talking about the plasmacytoid cell here. And if we have these eosinophilic inclusions in the nucleus, the presence of Ducho bodies. If it's in the cytoplasm, we have the presence of Russell bodies. So Ducho bodies and Russell bodies possible to see on a bone marrow examination when looking at the plasmacytoid cell. Okay, so the next kind of paraproteinemia that we want to discuss is multiple myeloma. In multiple myeloma, it's characterized by the malignant proliferation of plasma cells. The malignant proliferation. So they're not normal plasma cells, they're malignant. Malignant proliferation of plasma cells. Now we know initially we start with B cells and eventually we end up with plasma cells. So they have to mature from B cells to plasma cells, which eventually are going to secrete immunoglobulins. So let's put that into writing. We have the B cell initially, and then eventually a plasma cell. Okay, and then once it's a plasma cell, we're going to deal with the production of immunoglobulins, antibodies. Okay. Now, the immunoglobulins, normal immunoglobulin is polyclonal, i.e. we have a variety of heavy chains we can choose from, because we know we're made up of heavy chains and of light chains. So it's polyclonal. It has a variety of heavy chains it can be made up from, and a variety of light chains it can be made up from. The heavy chains, we can say there are 5 types. Okay, so polyclonal, 5 types, and 2 types of light chain. Okay, so this is the reason we can say they are polyclonal. Immunoglobulins are polyclonal. Now, in myeloma, the plasma cells produce immunoglobulin, but only of a single or heavy light chain type. Okay, which means they produce something called a monoclonal protein, otherwise known as paraprotein. So in multiple myeloma, we have the development of the monoclonal protein known as paraprotein. Paraprotein. Okay, so this is the problem with myeloma, is that it's no longer polyclonal, it's the production of a monoclonal protein known as paraprotein. Now, in some situations, we have only the production of light chains. So only light chains are produced, and this can be kappa chains or lambda chains, the 2 types. And we only have light chains, and they appear in the urine as something called Bence-Jones proteins. So in some situations, only light chains, and these appear in urine as Bence-Jones proteins. Okay, so only in some situations we have light chains. Only light chains. Okay, now it's important to know that the type of chain defines the type of antibody that we have. So the type of chain defines the type of antibody that we have. The malignant plasmacytes, the malignant plasma cells that we talk about, they also produce cytokines. They produce cytokines like IL-6, and these cytokines are going to have negative effects. Okay, so let's say the plasma cell is going to produce cytokines. Cytokines like IL-6. Okay, and these are going to have negative effects. They're going to stimulate osteoclasts, which is going to cause lytic lesions, which is going to have significant effects. So, stimulate osteoclasts, which is going to cause lytic lesions. And because of this, we're going to have a lot of problems. We're going to have possibly bone pain. We're going to have possible bone fractures. The calcium levels are going to increase, all because of the production of these cytokines. Fractures, bone pains, and increased calcium levels. So bone pain, fractures, and high calcium levels. All because of the production of these cytokines from this malignant plasma cell. So it's not a normal plasma cell, it's going to be a malignant plasma cell which produces these cytokines that are going to have negative effects on the body. It's also possible that the bone marrow might be affected. So we can have bone marrow infiltration of these plasma cells, and they can possibly even cause a pancytopenia. They can affect all the cell lines, the platelets, the red blood cells, the white blood cells, and we can also possibly develop a pancytopenia. So pancytopenia is also a possibility in bone marrow infiltration. Okay, so multiple myeloma, it's the malignant proliferation of plasma cells, malignant plasma cells. Initially we start as a B cell, we have a plasma cell eventually once it's matured. It secretes antibodies, immunoglobulins made of heavy chains and light chains. It's polyclonal, and normal immunoglobulin is polyclonal. 5 types of heavy chain, 2 types of light chain. But in myeloma, we have the production of a monoclonal protein. Only monoclonal protein known as paraprotein. Okay, so we don't have this polyclonal effect with all the different types. We have a plasma cell, a malignant plasma cell, which is going to produce cytokines like IL-6. This is going to stimulate osteoclasts. This is going to cause lytic lesions, which is going to have very negative effects on the body. Bone pain, fractures, increased calcium levels, and if it gets to the bone marrow, pancytopenia, possibly a decrease in all the cell lines of the bone marrow. So now, clinically speaking about multiple myeloma, how do we diagnose this? So clinically speaking, to diagnose multiple myeloma, we need 2 out of a certain 3 criteria that we specify. So 2 out of the 3 need to be present to have a positive diagnosis. The first criteria is we have an increase in malignant plasma cells. We have a high number of malignant plasma cells. So 1, malignant plasma cells, because we said this is the characteristic of the disease, increase in malignant plasma cells. Number 1. Number 2, we can say that we have either in the serum or in the urine, we have the paraprotein. We said that we have this monoclonal protein that is produced called paraprotein, and this has to be found either in the serum or in the urine. This is the second possible criteria. Serum / urinary paraprotein. Okay, so that's the second criteria. Now the third criteria is with regards to the bone lesions. So the third criteria is the presence of skeletal lytic lesions. We said the production of the cytokines is eventually going to stimulate osteoclast, which is going to cause lytic lesions. So third, skeletal lytic lesions. Skeletal lytic lesion. Okay, so we need 2 out of these 3 criteria to have a positive diagnosis of multiple myeloma. How about other investigations? So how can we investigate this a bit further? Of course, one of the most important will be to check the bone marrow. If we check the bone marrow directly, then it's possible that maybe we'll see these plasma cells, which will make the diagnosis easier. So 1, bone marrow aspiration. Number 1. Number 2 is we could do electrophoresis. We can do a plasma electrophoresis or even a urinary electrophoresis to see the levels of the, possibly if we can find this paraprotein. So plasma or urine electrophoresis. Okay, separating by charge and size. Okay, so that's another possible investigation. A third kind can be a possible bone scan, because we said that in this situation we have bone lesions, so if we do a bone scan, we can see if everything is intact regarding the bones, then possibly it might either confirm a diagnosis or rule out a diagnosis. So bone scan, or it might help towards making the diagnosis. Okay, so these are other investigations on top of finding these that could be important in multiple myeloma. So with regards to treatment in multiple myeloma, we need to know that the treatment is non-curable. We're not looking to cure the multiple myeloma, but simply to relieve the symptoms or stop the situation getting worse. So firstly, we need to consider giving the patient fluids because we have a hypercalcemia and we have a possible renal failure that could develop. So make sure the patient has high fluid levels, possible IV fluids. Another thing is we said that the bone pain might be very severe because of the lytic lesions. Bone pain could be common and you have to control this pain, so we need to give analgesia. Another drug we can give is bisphosphonates. We know that bisphosphonates can be used to treat this high hypercalcemia, and it's used also in osteoporosis to stop the loss of bone mass. But we know in this situation, when using bisphosphonates, there's a risk of developing osteonecrosis of the jaw. So when giving bisphosphonates, we have to make sure the patient has regular dental checks to make sure that the jaw isn't being affected. So bisphosphonates to stop this excessive calcium loss. Bisphosphonates. Okay, but we have to be aware because this can cause possible jaw osteonecrosis. Okay, so something to keep in mind. Okay, another thing that we can give to help in this situation is, we didn't mention it, but we said we can say possibly there's a development of a hyperviscosity syndrome because of this presence of the paraprotein. If it's in very high levels, it's possible we can have a hyperviscosity syndrome with hyperviscosity symptoms. So a possible plasmapheresis could be indicated in certain situations. Plasmapheresis. Okay, so plasmapheresis, I don't think it's something common, but it's good to keep in mind, I think. Now, drug-wise, chemotherapy is an option in this situation. With chemo, we can have, again, like a combination therapy with thalidomide, with corticosteroids like prednisolone, and also with an alkylating agent. If you use thalidomide, an alkylating agent, and prednisolone, this is usually indicated. And this can cause immunomodulatory effects and has anti-angiogenic effects, so it can help with relieving the symptoms of myeloma, but it's teratogenic. Okay, so let's just, before we go too far, let's say chemo, we can use thalidomide, we can use an alkylating agent, and we can use prednisolone. Okay, and they have good effects sometimes, however, they can have teratogenic effects. So it can affect malformations in the fetus and in embryos. So teratogenic. So during pregnancy, this can be very dangerous. Teratogenic effects. So you have to see whether the person is sexually active, whether they are possibly pregnant, because this can have some severe effects. Okay, so we have to keep treating the multiple myeloma with this therapy, this thalidomide alkylating agent and prednisolone, until the paraprotein level keeps going down, and once it reaches a plateau phase, once the paraprotein is no longer going down, we can stop this treatment. If the symptoms keep persisting, then again we have to try and induce another plateau phase. So if the paraprotein is still high, we need to induce another plateau phase, and we can do this with another drug called bortezomib. Bortezomib, and this drug, bortezomib, okay, and this drug is something called a proteasome inhibitor, and this can again have very good effects if this treatment has done everything it can. So it's a proteasome inhibitor. So this is the second treatment we can do to ensure that we get another plateau phase. Now all these treatments, like we said, can be used, but prognosis-wise, it's not very good in multiple myeloma. Less than 5% of patients survive for greater than 10 years. So it's a very poor prognosis, and it's a very bad diagnosis. So prognosis, less than 5% survive greater than 10 years. Poor prognosis. Multiple myeloma. Clinically, we said we need 2 out of 3 criteria. An increase in the malignant plasma cells, a high number of malignant plasma cells, serum and urine paraprotein present, or skeletal lytic lesions. If we have 2 out of these 3, then we can say we have multiple myeloma. Other investigations, bone marrow aspiration, electrophoresis and possible bone scan, and also other investigations, which we can see in the table. And treatment, we can have an increase in fluids to avoid renal failure and avoid hypercalcemia, analgesia for the bone pain, bisphosphonates that we can also use in osteoporosis, but they can cause jaw osteonecrosis, so we need regular dental checks. If there's a hyperviscosity syndrome, we can do a plasmapheresis. Chemotherapy is possible with thalidomide, alkylating agents, and prednisolone. We try and induce a plateau phase, so we keep the paraprotein going down until we reach a plateau phase, where we can possibly use another drug. This can be bortezimib, which is a proteasome inhibitor. The prognosis of multiple myeloma is very poor, and less than 5% survive greater than 10 years. So that's multiple myeloma. Okay, so now we can go on to our next main topic, which is aplastic anemia. We finished with the paraproteinemias, we talked about Waldenstrom's macroglobulinemia, and we talked about multiple myeloma. Now aplastic anemia, completely different topic. We'll start with primary idiopathic aplastic anemia, then going on to look at the secondary causes of aplastic anemia. We need to know that it's a very rare condition, so it's not something we should expect to see very often. And basically what happens is we have the failure of the pluripotent stem cells, which therefore causes a hypoplasia of the bone marrow, which therefore results in a pancytopenia. So failure of the pluripotent stem cell is the first step. Failure of the pluripotent stem cell. This is going to cause bone marrow hypoplasia, which is going to result in pancytopenia. So a decrease in all the lines being produced in the bone marrow. So this is the typical reason, this is the effect of an aplastic anemia. To diagnose a primary idiopathic kind, we of course have to rule out other kinds. The secondary causes, which we're going to talk about, and the congenital causes, we have to rule out these in order to be able to say this is a primary or idiopathic. So must rule out secondary causes and congenital causes. Okay, so these have to be ruled out in order to diagnose a primary idiopathic kind. Now clinically, what are we going to see in an aplastic anemia? Of course, we said pancytopenia. We're going to see typical signs of bone marrow failure. So clinically, all the typical signs of bone marrow failure. And these are going to be anemia, it's going to be bleeding, it's going to be high rates of infection, bone marrow failure. Anemia, all the signs of anemia, possibly presenting with pallor, bleeding, easy bruising, and high rates of infection. So keeps picking up all these infections and doesn't know why. Okay, so typical signs of bone marrow failure. When we investigate the disease, we're going to see Of course, pancytopenia is going to be a clear sign. On full blood count, on bone marrow examination, we're going to see hypocellularity because we have this fibrosis of the bone marrow. So hypocellularity, we're going to have a possible fatty change also. So on investigation, let's start with the full blood count. We're going to have pancytopenia. On a bone marrow examination, we're going to have hypocellularity. Okay, and possible fatty change. So possible fatty change also. Okay, so these are typical investigations. Just a full blood count and a bone marrow examination can lead to the big suspicion of an aplastic anemia. Now, to treat this, there's no clear cure for this apart from a bone marrow transplant, which in a lot of situations is very unlikely. So supportive treatment is very important. Supportive treatment especially for the signs of bone marrow failure. So anemia, transfusions, bleeding, platelet transfusions, high infections, treat the infections with antibiotics, and possibly a prophylaxis to protect against the picking up of infections. Now in the young, like we said, bone marrow transplant is an option if the person is compatible and it's a realistic possibility. And in up to 90% of these cases, we can have a cure for the aplastic anemia. So let's say treatment. Let's say mainly we have to do supportive. For bone marrow failure. Okay, supportive treatment for this. A bone marrow transplant, like we said, is also a possibility. In the elderly, it's very unlikely we can have a bone marrow, so immunosuppressive therapy is usually indicated in the elderly, and this is with cyclosporin and can be with anti-thymocyte globulin is another option. Cyclosporin and anti-thymocyte globulin. So cyclosporin, anti-thymocyte globulin, and this can be immunosuppression. Immunosuppressive therapy, and especially indicated in the elderly, has good results with an increase in the survival. Also important to note that this condition, the aplastic anemia, can either develop to a myelodysplastic syndrome or to an acute myeloid leukemia. So eventually it can get that bad, it can develop into a leukemia, and possibly before a myelodysplastic syndrome, because we said a myelodysplastic syndrome can occur before the inevitable progression to acute myeloid leukemia. So idiopathic aplastic anemia, it's failure of the pluripotent stem cells, which is going to cause bone marrow hypoplasia, which is going to result in pancytopenia. This pancytopenia is going to cause us to have typical features of bone marrow failure, which are anemia, bleeding, and infection. To investigate this, of course, a full blood count will show pancytopenia. Bone marrow examination will show hypocellularity, and possible fatty change. Treatment is supportive. We have to treat the anemia, treat the bleeding, treat the infections, or protect against further infections. Bone marrow transplant, if it's a possibility. Cyclosporin and anti-thymocyte globulin in immunosuppression, especially in the elderly people, which can help in increasing survival. Possibly this can develop into a myelodysplastic syndrome or an acute myeloid leukemia if it becomes very severe. So it's a primary idiopathic aplastic anemia. Just a very, very quick word about secondary causes of aplastic anemia. We know that there's a lot of secondary causes. There's many, many causes and many, many drugs specifically that can cause a secondary aplastic anemia. So if it's suspected, possibly look at the drug list, look at the previously taken drugs by the patient and see whether one of the possible side effects was the development of a pancytopenia and aplastic anemia. The clinical features, the investigations, the management is all going to be the same as the primary causes of aplastic anemia. But there's a long list of drugs that can cause aplastic anemia.